Hi, this is Ulka Vaishampayan. I am a GU medical oncologist at Karmanos Cancer Center in Detroit, Michigan. My focus of my career has been to conduct clinical trials predominantly in GU malignancies, and that is the focus of my clinical practice as well. I also have a tremendous research interest and focus in developing novel therapies in cancer treatments. The recent focus of treatment has moved towards personalized medicine or customized therapies, and that has led to this whole new era of what we call as PRRT, which is Peptide Receptor Radionuclide Therapy. The principle of this is you use a peptide or a protein or an antibody that would attach to a protein that is overexpressed on the cancer cells, which in turn can be tagged with either radiation or chemotherapy, and eventually be able to be delivered to the cancer cells, potentially with affecting or saving the normal cells, the toxicity of this treatment. The radionuclide therapy, or PRRT, specifically refers to using radiation isotopes that are then attached to different antibodies that would attach to the cancer cell, and these antibodies would change based on the type of cancer you're treating. There is antibody drug conjugates, which are chemotherapy that is tagged to antibodies that is also delivered to the cancer cells with a specific mechanism, still given IV, but the idea being that the chemotherapy would predominantly be released at the cancer site and avoid or spare some of the normal tissue adverse events or side effects. So one of the newer treatments within the PRRT, which is going to be the focus of the discussion today, is a therapy called PSMA Lutetium 177 treatment. And what this is a treatment that is specifically designed for prostate cancer therapeutics. This whole field is also called something like theranostics, which means that this is therapy with, again, target is the cancer itself and attempts to spare normal tissue. So PSMA is a protein that is fairly frequently overexpressed on prostate cancer cells. And the idea here is, again, similar to what I described before, is attaching a radioisotope to the PSMA antibody, which would then in turn be released as the antibody and the radiation package gets attached to the prostate cancer cells. The first step, of course, to this process is to detect if the cancer expresses PSMA, and this can be done with a Psma Pet Scan, which is a very sensitive PET scan that allows you to detect areas of prostate cancer. About 10 to 20% of patients will not adequately overexpress PSMA on their cancers, in which case this treatment is unlikely to be effective or helpful in those patients. So doing the Psma PET scan allows you to determine how much of their cancer is expressing the PSMA or the prostate-specific membrane antigen, and then allows you to plan or gear towards this therapy. Now, at present, this treatment is not FDA approved here, and there is a large registration trial, a phase 3 randomized trial that has completed accrual, and follow-up is ongoing and results are awaited of this study. The study is called the VISION trial, and that randomized patients with metastatic castrate-resistant prostate cancer post at least one prior chemotherapy, such as docetaxel, up to even prior other chemotherapies were allowed, up to 2 prior taxane-based chemotherapies were allowed. And following this, the patients were evaluated and were eligible for the study at a minimum after one chemotherapy regimen. If patients had failed at least one standard chemotherapy regimen and one androgen receptor targeted agents such as abiraterone, enzalutamide, any of those treatments, then the patients were eligible to be considered. The patients had to have a PSMA scan to see if their cancer tissue did express PSMA. And following that PET scan, they were randomized to either get standard of care or they were randomized to the PSMA lutetium therapy. The standard of care could consist of any of the hormonal agents were allowed, steroids, external beam radiation was allowed on the standard of care arm, and this was given regardless of which arm the patients were randomized to. The PSMA lutetium therapy is given once every 6 weeks as an IV infusion or injection. We gave it as about a 5-minute IV injection. The patients do have to be monitored for an hour or so, and afterwards they were advised to avoid exposure to crowds or even to stay about 3 feet away minimum from any of their family members for about 48 to 72 hours due to the possibility of radiation exposure. Besides that, however, the tolerance of this therapy from other trials, phase 1, phase 2 trials that have been conducted across the world, in Europe predominantly, the side effects have been noted to be dry mouth because this can affect the parotid gland secretions, and then potentially myelosuppression has also been noted. Overall, this therapy has shown promising preliminary efficacy, and as I said, the results of the phase 3 trial are awaited, which may give us data to see if this therapy represents a true advance in metastatic castrate-resistant prostate cancer for patients where there is clearly a huge unmet need for developing novel therapies that would help both with potentially improving life expectancy or survival, as well as improving symptoms.